From the News Channel 5 Network, this is Medical Mondays.
Good evening, everyone. Thank you so much for joining us here for Medical Monday right here on News Channel 5 Plus. Tonight's topic, one that a lot of us can relate to, one of the most talked about cancers, that is breast cancer. And tonight we're talking about some good news, advances in treatment. And who better to join us this evening than Dr. Pat Whitworth. Thank you so much for being here tonight.
It's great to be here.
Well, we're happy to have you on, and you know, we have some new things to talk about and new treatments, as well as a device that you actually brought with you here this evening. It's called BioZorb. I actually have a few there on the desk for us, and we're going to talk about all this tonight, as well as just different facts and things to know about breast cancer. I think it's definitely a cancer that pretty much everyone we know has been affected by, which is why we're glad you're here tonight.
Thank you. It's good to be here.
Well, let's kind of kick the show off tonight. I always like to remind everyone that we want you to call in. We want to hear from you. Any questions that you may have, stories you want to share, any comments you may have, please call into the Plus. I'm going to go ahead and give you that number here to start off our show tonight. It's 615-737-PLUS. Again, 615-737-7587. I know, Doctor, we'd love to hear from everyone tonight. Well, let's go ahead and kick things off. I'd love to hear, I know you're kind of a frequent guest here on News Channel 5, but just to kind of remind folks a little bit about your background and how you kind of got into the medical field, Doctor.
Okay. Well, I started out in Tennessee. I grew up in East Tennessee and went to school in state, did my general surgery training in Louisville. And while I was in Louisville, you know, you try to think about what am I going to do long term? Is there something that's a specialty that's more attractive? And I ended up really realizing that the folks my heart always went out to were patients with cancer. You know, they had something they had no business, you know, they did not cause it. It really wasn't related to a lifestyle choice in most cases. And I ended up going to the MD Anderson Cancer Center in Houston from 1988 to 1991. So then I came to Nashville.
Yeah, it's incredible to hear folks' stories, kind of what led you into the field. And over the years, you know, the advancements you've seen, kind of the changes. Can you tell us about some of those?
Well, you know, there were a lot of things when I first started in practice we were really looking forward to. We knew that we were treating too many people with chemotherapy. We knew chemotherapy helped. We just didn't have a good way of determining who it would help. And around 2004 and 5, we finally got information and ability to analyze a tumor, a woman's individual tumor, and to say, this is one that doesn't need chemotherapy, and most don't. But here is one that really does. And so it was something we'd wanted a long time, and finally we're able to give information to women so that, you know, some women who needed it would get it, but the women who were so scared they would need it and didn't need it wouldn't get it. Mm-hmm. So that's one of the things. There are so many things that have changed. We've gotten a lot better now at something we call oncoplastic surgery, so that in the past, I think the attitude was, you know, you've been cured of breast cancer. This is good news. This is great. And so you have some battle scars. Well, you know, that's okay. And now we are much more of a mind that women need to really have their whole sense of self back, and they need to really look good, maybe even feel like they look better than when they started. So we've begun to add plastic surgery techniques to cancer surgery techniques, and they really do go together, and we really can have very pretty results. So that's another advantage. And I guess the other thing is, after surgery, women are concerned a lot of times about lymphedema, about swelling in their arm. And so we have some big advances in that area too.
No, I definitely want to talk about some of these things tonight because, you know, it is obviously very traumatic for someone to go through this, to hear the news, and then to go through all of the treatments. It definitely takes a toll on you. And I think, again, a lot of us do know folks that have been affected by this. And that's why tonight, you know, I'm kind of excited to talk about some of the treatments that we're seeing and some of the advancements that, you know, doctors have been making. In fact, you actually brought something with you tonight that we're going to be talking about a lot this evening, and it's called BioZorb. Tell me why you wanted to bring this evening and kind of discuss this.
Well, you know, women are first concerned, am I going to live? And am I going to be able to do the things I did before? But then they're also a little concerned about their appearance, and rightly so. It's upsetting to have to remember you've been treated for breast cancer because you're not as happy with your appearance. So more and more these days we do lumpectomy instead of mastectomy. We still do both, but we are really learning that lumpectomy gives us the same cure rate, and it's a lot easier on folks. But if you do a lumpectomy and you don't do anything to kind of make up for it, that area of the breast can sink in, can collapse a little bit. So we do some plastic surgery techniques, oncoplastic surgery we call it. We do a little lift in a lot of cases. The women who have breast cancer often are in their 50s and 60s, and the breast tissue has moved down a little bit, so we can do a little lift. But this device is sort of a partial breast implant, but it's temporary. It dissolves over the course of about a year and a half or 2 years, so that we can really put a little scaffolding in there, and as that breast tissue heals, it heals in that nice full format instead of collapsing.
Now, when you first saw this device, what was your initial reaction to it?
I was pretty excited about it. You know, we see a lot of new things, though, and so you have to be skeptical at first. The advantage here is this device was really developed and originally was meant for, and still is, for guiding the radiation. So this little spiral that you'll see, most of it dissolves, but there are little metallic markers in there that are very small, but the radiation doctor can see those on an x-ray and can guide the radiation so that we don't have so much radiation to areas you don't need. It can really focus on that area where you do need it.
It almost serves a double purpose in a way. So it's a filler as well as an indicator.
Yes.
Incredible.
Exactly.
And we actually, they're laying right there on our desk. Let's go ahead and we'll kind of show these to folks.
Should I pick them up?
Yeah, I think we should. I mean, we might as well. We brought them here, and I mean, these are really incredible, and I'll leave you with this one. And now what you can see here, again, we're talking about a device called BioZorb tonight. With us, Dr. Pat Whitworth of the Nashville Breast Center, just talking about the advancements in breast cancer treatment, of course. This is an interesting device, and I'm going to hold it down a little bit lower here so folks can see it. You know, it's just amazing, some of the advancements that we're making, you know, in treatment. And as a doctor, again, I asked you, your initial reaction, so let me ask you, how long has this been around now?
It's been around close to 3 or 4 years. I've only been using it for a couple of years. We are all, as I said, some of us adopt things very quickly, and we tend to do that. But this was really impressive as a way of not only guiding the radiation, to targeting the radiation better, but it was clear from almost the very beginning that you could really support the breast tissue while it was healing, so that it wouldn't flatten out, so that it wouldn't collapse.
Okay, and so how many surgeries would you say you have actually performed using this device?
I would say somewhere in the neighborhood of 30, something like that.
And what's kind of the feedback that you get? Is it something that, I mean, most folks, they never really had this surgery before, so it's hard to tell one way or the other, but what would you say the overall outcome has been for you?
Well, initially, especially, women are happy to see that their breast looks the same, or the shape looks the same. It doesn't look like they've lost anything. And then they can feel it a little bit, though, so you have to be reassuring about that. But it softens up after about a month, and again, after about a year and a half or 2 years, it has dissolved, and the tissue by that time has had a time to sort of form in that shape.
I mean, again, if you're just tuning in, we're talking with Dr. Pat Whitworth tonight just about different advancements in breast cancer treatment, and one of the most common uses for this is when a lump is removed from a breast. I mean, you're dealing with, it could be a rather large area, that this is a perfect device to basically serve as, I mean, it's a spring device as well.
Yeah, that's the largest one. This is probably something we use more often, right, in this size. But it really depends on the amount of tissue that we've had to remove, so that we fit that space, and we don't want to expand it, but we don't want to collapse it either.
Obviously, a larger tumor, you're going to use this one, smaller tumor for that one. That was one of my first questions when you actually showed up tonight and brought this device in, was, what is kind of the difference? Why the two different sizes? And one thing to note, too, that you had mentioned earlier, this actually, it dissolves over time, so there's no needed surgery to remove it. Is that correct?
That's right.
What an advantage as well. So some other just kind of reactions to this, to you and your friends in the medical field, just some, obviously, it's a device that I'm sure you all are excited about, and any other kind of feedback that you've been receiving from this?
I think all of us have been pleasantly surprised. We were initially, fairly easily convinced that it was going to target the radiation better. But was it really going to help with the cosmetic outcome? Was it really going to support the tissue in the way we thought? Were women going to be happy with it? And all of those things seem to be moving in the direction that really surprising us with how well things have gone.
That's what it's all about. Wonderful. Well, we'll stay right here on The Plus. We'll be right back to talk more about these amazing advancements in treatment. We'll be right back on your Medical Monday.
I'm doing things much better now.
It's working for me. He brought me back to life.
Be your best with Talk of the Town.
I'm Dr. Kevin Mitchell from the Wellness Institute of Nashville. Non-surgical spinal decompression is a state-of-the-art technology that brings in blood and nutrients and fluid into the spinal disc. Any patient that's had back pain, either acute or for long periods of time, anyone that has tingling in their arms or legs or weakness into their extremities is a candidate for non-surgical spinal decompression.
I had gotten to the point where regular doctors treating me for pain in my back just weren't helping.
I couldn't even walk. All I would do is lay in the bed, and that's not a life.
I had a bulging disc in my neck, pushing on a nerve.
It allows the fluid to come into the disc, and it'll literally reverse the pressure of that disc. And the unique thing about this procedure is there's no medication, there's no surgery, and no injections.
Oh, I'll tell you, you feel so much better.
I decided to give it a try, and I don't regret it.
If you're suffering pain, don't settle. Come and see me today. For the first 40 callers, they can have an examination, x-rays if needed, x-ray report, bring your MRI if you have one, and we'll go over that as well for only $29. If you have pain, you no longer have to settle for that. Pick up the phone, give us a call here today at the Wellness Institute of Nashville.
Ponce Law made me feel like they were going to take care of everything, and they did.
I would describe Michael Ponce's firm as caring, aggressive, and passionate.
From the time I walked in the door until we closed, it's been a great experience.
Quality of service that they perform in the courtroom and out of the courtroom is tremendous.
You cannot go wrong with Ponce Law.
Ponce Law, justice for all. 615-244-4321.
To be able to just get my son here and not think about how we will pay for it, it just takes so much weight off of my family. St. Jude allowed me to focus on being a mom to Bryce. And sometimes I'm just in awe of the impact St. Jude has, not only on this community, but the world.
To follow breaking news.
Breaking news that matters to you.
Traffic is backed up.
Can come from anywhere.
Protesters have been
at any time.
Showers expected.
See it as it happens.
Rolled over school bus.
Wherever you are.
Storm cell that's coming through.
News Channel 5 streaming live.
Quite a bit of lightning here.
Live streaming of News Channel 5 is sponsored by Universal Kia.
Well, good evening, everyone. Thank you so much for joining us right here on News Channel 5 Plus for another Medical Monday. Tonight's topic, a very interesting one. We got Dr. Pat Whitworth here with us this evening to talk about the advancements in breast cancer treatment. Doctor, thanks for being here tonight.
Oh, thank you. It's a pleasure.
Again, if you're just joining us, we always want to let you know that we do love to hear from you, able to answer some questions this evening, so go ahead and call in. Again, the number is 615-737-PLUS. So go ahead and phone in to us. We'd love to hear any questions, comments, or stories that you may have, which kind of leads us into our next segment here. We're going to go ahead and take a phone call from, I believe it's Raina, that we're going to hear on line 1 here. Good evening. Can you hear us okay?
Yes.
All right. So you're on air right now. What question did you have for us tonight?
How the treatment he's talking about compares with the brachytherapy treatment.
That's a great question. So, doctor, kind of touch base on that.
The caller is really well educated about the topic because there are several different ways to give radiation. And brachytherapy is really giving radiation in a little small space. So we do something we call accelerated partial breast radiation. Some patients are candidates for partial breast radiation where we only radiate a small part of the breast. To do that, we put a catheter in the lumpectomy pocket, and the patient can get her radiation twice a day for 5 days. So many women are candidates for that, and those women often opt to do that 5 days treatment, even though you have to walk around with a catheter in that lumpectomy pocket, because the more standard radiation is 6 weeks. It's every day, Monday through Friday, for 30 treatments. This device is used with that more conventional standard whole breast radiation, but again, it does help target that whole breast radiation so that the radiation doctor can focus more on the area that's needed and away from the lungs and away from other parts of the body. So it is a choice, and that's a very informed question. If we have this little device in the lumpectomy pocket, we can't put that little catheter in. So we're often making a choice. That lady says, you know, I live too far away to come twice a day. Those treatments for brachytherapy, the partial breast radiation, are twice a day. And they'll say, gosh, I live too far away. I'm going to get radiation near my home. What are my alternatives? And so we'll frequently use this in that situation. In other situations, because of the particular cancer, that patient is better off with whole breast radiation. So those are a couple of the choices that we have. We also have a number of choices as far as the cosmetic side, the oncoplastic techniques that we use. Some women have all their life thought to themselves, you know, I'd like to get a breast reduction. They haven't done it. They've got other things to do. They're busy. But those women sometimes come in and we find that they need a partial lumpectomy. It's called a partial mastectomy or a lumpectomy. And we can let them know, you know, we can combine that lumpectomy with a reduction mammoplasty. There is a 1998 Federal Women's Health Act law that says that insurance covers the opposite breast for symmetry. So that the plastic surgeon comes in and works with me. We work together. They'll assist me, I'll assist them, and we'll not only do that lumpectomy, but as a part of that, we'll do a reduction mammoplasty. And that gives us the ability to take more tissue and still have a very pretty result. So that's one option.
Is that all in one surgery then?
Yes.
Wonderful. That's, you know, great news for the patient as well. We do have another caller here. This is Nancy on line 2. Can you hear us tonight, Nancy?
Yes.
Wonderful. What's your question this evening?
Okay, my sister passed away with breast cancer. My question is there a blood test that I can get to tell me if I'm carrying the gene for breast cancer?
Thank you for calling in, Nancy.
That's a great topic. You know, up until just a few years ago, we could only test for 2 genes, BRCA1 and BRCA2. And those genes are pretty strong risk factors. If you have BRCA1 mutation or a BRCA2 mutation, that gives you a pretty high risk for developing a breast cancer sometime in your life. Since that time, and that was in the 90s, we started testing for those 2 genes. A woman named Mary Claire King, against the advice of all her scientific friends, said, I think I'm going to find this, and she found it. So she's sort of an American hero. But since that time, we test now, in some cases, for 80 different genes.
Wow.
Some of these have a much weaker association, but some risk. Some of them we don't know that much about, but we know there's some association with breast cancer risk. The good news is we are beginning to relax all the rules we had about who to test. Those rules were originally made around the BRCA genes, which show up very young and very strong family history. And not everybody is young. Not everybody has that strong family history. And what we are finding is that these additional genes really show up not so much in that young, strong family history pattern. They can show up in a woman who's 60 or 70. And originally, one company had a patent on doing this testing. And because of that, the charge was about $4,000 per test. The charge now is down in the $250 to $450 range for many of these tests. And if you're paying for it on your own, or if there's a high deductible, that's something that you may want to consider. But that alone has forced all the companies to become much more patient-friendly. They work with patients, even if they have a high list price, they're working with patients to really make it easy on them. So there are 5 or 6 companies that are doing this kind of testing. The company that always did BRCA1 and 2 testing is now testing 25 genes. So I advise women, when we have a breast cancer patient, we are testing those patients now as part of a study that we're doing. Any patient that comes in. Now that's not there are guidelines that say only test this narrow group. We're missing a lot of women when we use those guidelines. So we've expanded that in a registry study that we're doing. But also, and it's important if you can, to test the person who had the cancer, because there's only a 50-50 chance of passing that gene on. You know, you have 2 copies of each gene.
Oh, okay.
So when you have a child, that child just gets 1 copy of the thing you have 2 copies of. And so they could get the good copy you have and not be at risk, or they could get the bad copy. And what that means is if we test the person who didn't have breast cancer, if we test our caller instead of her sister who passed away, we can't test her sister, then there's only a 50-50 chance we're going to pick that up in her family. So we try to find somebody to test, but we often can't. And so we would test her after letting her know what those options were.
And I'm curious, can you kind of walk me through the testing? Is it something that's pretty complex to explain, or is it just,
No.
I'm just curious about that myself, a question I have for you.
Well, and you know, we can now, scientists and the companies that do this work can sequence your whole genome. They can sequence all of your DNA.
Wow, that's incredible.
You've probably seen some of the companies that offer that testing more commercially, but the medical labs that are really doing this for disease diagnosis, so they can do your whole genome. So now we are really trying to figure out what's the best way to deliver this. Do you give people information that may just scare them and not help them? There are a lot of huge controversies around this. But we do believe that with regard to the breast cancer gene testing, because it has become so inexpensive and so available and so doable, we need to be testing more people, and we need to to gather that information up so we don't lose it. It's a saliva test. You know, some of the commercially available things that you can do online are just you send a little saliva in a cup, or we can do a blood test, either one.
Is one more accurate than the other, or about the same?
If you get a good sample, then they're pretty equally accurate. The saliva test can be messed up if you are chewing gum or something like that. So sometimes a patient will be in the office and they'll say, well, I'm ready to get that test, and we'll find, well, we have to do a blood test. But they're very straightforward. There's a little trickiness with making sure the insurance coverage is right, or if somebody's paying out of pocket, that the company knows that, because they charge a little differently that way.
You know, we'll get back to the BioAbsorb device, but right now I want to go ahead and dive into just a little bit about breast cancer, you know, kind of the basics really. Any idea, any causes? What is causing this cancer?
Well, we know in general what's causing it, and it's a problem with regulating DNA. You know, cells in your body are always having to grow. And cells grow by one cell dividing into two, you know, and those two dividing into four. When you've had a cut or an injury of some kind, or just one cell gets old and it needs to be replaced. But that cell growth is highly regulated, you know, and there are other genes that really produce proteins that sit on the DNA and say, okay, the brakes are on, stop dividing. We don't need any more dividing. We've got this area perfectly healthy. And so cancer happens when those genes break, when you lose one of those genes that slows the other genes down, or when you lose one of the genes that repairs other genes. In fact, BRCA1 and BRCA2 and most of the genes we test for are really not breast cancer genes. They're DNA repair genes. But if you have a problem with repairing DNA and a cell gets a problem with its DNA, it's either going to die or it's going to start growing out of control. And so cancer is a cell that's growing out of control and has acquired the ability to travel other places.
You know, who gets breast cancer? Who are your candidates? And I'm curious too, are you seeing this becoming something in younger women more and more?
We are diagnosing younger women more and more. Part of that is awareness, part of it is a little better screening. But this is a really surprising statistic to most people. Most women who we diagnose with breast cancer don't have any family history.
Wow.
And so I see patients all the time who are literally shocked. They say, I can't have breast cancer. Nobody in my family has it. And just because it is so common, 7 out of 10 women who have a breast cancer don't have any family history. And that's why you hear all of the encouragement to get your mammograms, to get the proper screening. The other thing that's very important is to consider the patient's own individual risk. You'll hear recommendations or guidelines for mammography. Start at 40, start at 50. And we do recommend that women start at 40 and get yearly mammograms as an average. But those recommendations are all for women who have average risk. If a woman has a family history, there are calculators that you can use online that tell you your lifetime risk is not the average 10 to 15%, your lifetime risk is 15 to 20%, or your lifetime risk is over 20%. If your calculated lifetime risk is over 20%, we start to include more things in your screening, like breast MRI.
All right, we'll keep it right here on 5 Plus. We'll be right back with more Medical Monday.
This is a Storm 5 HD weather update. Sign up for Weather Call at newschannel5.com.
Hi, everyone. I'm News Channel 5 meteorologist Leland Statham. Thank you for watching News Channel 5 Plus. Radar rain free for us here in the mid-state today. There could be a stray shower toward the west state, but most areas will be dry. Check out what's happening right now as far as our temps are concerned. Another very warm day. The normal high 79. We're shooting for 91. The record today, 92, set back in the 1800s. Let's show you what's happening right now from Nashville International. So your Tuesday forecast, looking for a high today of 91 with a wind east-northeast right around 5 miles per hour for you today. Meanwhile, overnight tonight, mainly clear down to 66. We're still at 90 tomorrow. Cool fronts on the way. It may squeeze out a stray shower Wednesday, Thursday. Most folks dry, but it will bring much cooler weather for the weekend ahead.
I started Ponce Law here over 20 years ago to help people who have been injured. Ponce Law, justice for all. 244-4321.
The USA has lots of buried pipelines, so it's important to know the signs of a leak, like if you smell unusual odors or hear hissing, see bubbling earth or water, or dead or dying vegetation. Some signs are even harder to miss, like dirt being blown into the air, a frost ball in an open field, or a flame coming from the ground. If you see any of these signs, don't wait. Leave the area immediately and call 911 or your pipeline company.
Visit pipesafety.org. Brought to you by the Tennessee Gas Association.
Our community is rising, and in the push and pull of progress, trust is everything. The News Channel 5 network runs toward the future, eager to tell it all and keep a watchful eye over everything you hold dear. Thank you for trusting News Channel 5 to be your news and information leader.
Well, good evening, everyone. Thank you so much for joining us right here on News Channel 5 Plus. You're watching Medical Monday. Joining me tonight, Dr. Pat Whitworth, and we are really diving into a lot tonight, dealing with just the advancements in breast cancer treatment, and also some of the new devices that have come out, and just really answering some great questions from our wonderful viewers. We do love to hear from you, and of course, Doctor, happy to answer those questions as well. Thanks so much for being here tonight.
Thank you.
Some topics that we want to get into. We were kind of going into just some of the basic questions. What is breast cancer? Who typically is diagnosed? And, what can we do? I kind of want to continue with that topic. Now, what are some of the symptoms of breast cancer? Of course, early detection is so key and vital, but as a doctor and folks tuning in tonight, maybe what are some symptoms we can keep an eye out for?
There's a whole list of symptoms that we say, okay, this is a red flag, we have to check it out. Most of the time, those symptoms are not really breast cancer. Some of the time they are, so we have to look into them. But I see patients every day who are really terrified. Maybe they have some nipple discharge, or maybe they've found a lump, or they have a pain that's really sharp in one spot. And those are the things we have to check out. They almost always are benign and nothing bad. But it's one of those things where we have to check. So we're never disappointed if it's, women say, well, I'm so sorry, I should apologize, it wasn't anything. We say, no, this is good, you did the right thing, you should check it out. But those are the main things. A dramatic change in the breast, a lump that doesn't really go away and it doesn't really go with a woman's cycle, any kind of a change of appearance where you see some indentation or dimpling. Now, these are not things that are cancer. These are things we just check when that happens.
What are some of the types of breast cancer? I mean, it really does vary. There are different stages, and just kind of touching base on that as well.
This is an area where we have made absolutely fantastic progress. In the past, we sort of looked at, well, how big is it? And is it in the lymph nodes? And we would stage it. And so people ask that all the time, what's my stage? But we now know that there are some very important types, and the real importance is it relates to what kind of treatment works for that type. In fact, it's, the analogy would be, you get an infection. If you're going to take an antibiotic, you want to make sure it's one that works for that type of infection. It's not resistant. So most breast cancers are hormone dependent. Most breast cancers we can attack with either a hormone blocking agent or something like that. That's more often in the most commonly affected group, which is women in their 50s and 60s and maybe 70s. Women who are younger or women who have one of those gene abnormalities can often have a breast cancer that is not in that most common hormone-dependent group that's sometimes called triple negative. It's estrogen receptor negative and progesterone receptor negative. That's 2 of the triple. The other thing is something we call HER2, and this was one of the biggest breakthroughs in breast cancer treatment. In fact, most people would consider it one of the biggest breakthroughs in the last 2 decades. And with HER2 positive cancers, there are extra copies of a gene that makes a growth factor receptor. You know, a growth factor receptor is sort of like the switch that the key fits in. And those growth factor receptors sit on the surface of the cells. And if something triggers them, that makes that cell begin to divide. You know, we talked about regulating that growth. Well, some HER2 positive cancers have way overmade those receptors. There are extra copies of that gene. You have too many of those receptors. Not only that, they are switched in the on position. So those cells are really growing. And so what happened was, first a drug called trastuzumab or Herceptin was developed. It's an antibody. It's not really chemotherapy. In general, chemotherapy just, you know, harms any cell that's dividing rapidly. Herceptin is a silver bullet that goes straight to those HER2 receptors. There's another new drug called pertuzumab that does the same thing. So for those women who have a HER2 positive breast cancer, we now, instead of, in the past, we'd say, wow, that's an aggressive cancer. We're really concerned. What are we going to do? Now we say, oh, good, you have the HER2 positive cancer. You know, we commonly combine those silver bullets with conventional chemotherapy, but your chance of cure is superb. It is excellent instead of being scary like it was in the past. So we sort of have these big groups, either triple negative or HER2 positive or hormone dependent. And so once we classify those and do some very fancy, what we call genomic testing to confirm that, we have a much better idea of what treatment that patient needs.
It's just incredible, the advancements that have been made and then just continue. Every year, are you seeing just something change, and is it that rapid?
It is. In fact, doctors, it's hard to keep up. There is literally an avalanche of information coming out all the time, and so that's why I'm very spoiled, because I narrowed my practice down just to breast care. I'm a cancer surgeon, a surgical oncologist, but I just do breast care, and that makes it easier for me, but it is still an avalanche of new stuff.
Let's go ahead and talk about your practice. If you being here tonight, tell folks a little bit of information or any sort of, you know, even stories that you want to share this evening.
Well, we see a lot of women who have just had an abnormal mammogram and they're scared to death, and or found a lump, that sort of thing. We do a lot of the diagnostic biopsies. We work with some of the radiologists in the hospital as well. And so most of those women, we end up getting to give good news. And that's kind of a happy part. You know, you have somebody who's very scared and you get to say, guess what? It's nothing bad.
What
so
a
that
relief.
happens, yes.
Yes.
In fact, if a woman has a mammogram that says you need a biopsy, only 1 in 5 of those is cancer.
Wow, that's a great statistic.
It is. It really is. 4 out of 5 are not. But if we try to get better at, you know, not doing biopsies, we start to miss some things. So we have that kind of low bar of a 20% risk overall. So if a woman is diagnosed with cancer, the good news is that the vast majority of those are cured. And I've got to confess, I use the news as a little bit of an example. I tell women, you know, when you watch the news, they don't show you in Nashville, 200,000 women just drove home safely yesterday. They show you the car wrecks. And so you will hear the scariest stories. But we expect to cure this, and most of the time we are right. We'd win a lot of money betting that person's going to be fine.
You're on to us. He's on to us. Oh, no. That is a great analogy, though. I mean, we're not going to cover the 90%, the normal, you know, like, that's a great analogy and very, very true. And it's wonderful to hear, you know, there is most of the time delivering that good news. And, you know, I think, too, a lot of women, it's scary to make that appointment, and, you know, just to stress that you do need to go seek, you know, that treatment. You need to get that answer. And if you do feel like you maybe have something that is abnormal, you need to go see a doctor like Dr. Whitworth. And let's talk about how folks can get a hold of you, where your center is located, and just some other ways to kind of, if you feel like maybe you do need to seek some, you know.
Well, we're part of a large group of doctors called Advanced Health. And Advanced Health has specialists in all areas. It's a great group. Our practice is called Nashville Breast Center. And you know, NBC, it's kind of easy to find. People call us on the phone.
Another news analogy.
People call us on the phone sometimes and say, I'm looking for the National Breast Center, and we don't correct them. We say, okay, you found it, come on in. But we're pretty easy to find, I think.
But let's talk about the location in Nashville. I mean, you probably could have practiced anywhere. Why Nashville?
Oh, well, having grown up in East Tennessee and trained for 3 years in subspecialty training in Houston, Tennessee was a natural place, and of course Nashville had such an academic environment. I first looked at work at Vanderbilt. I met some doctors who had a very exciting practice in the St. Thomas and Centennial area, and that's where I started out, 1991. My office is in the medical office building next to St. Thomas Midtown now.
Great location as well. And of course, I believe, yes, we do have, real quick, I want to go ahead and give folks the Advanced Health Referral Line. That's 615-986-6033. There's the information there on your screen. Of course, email appointment requests to medicalmondays@ouradvancedhealth.com. Be happy to hear from you. And again, there's that referral line there on the screen. Or you can also visit the website advancedhealthmedicalmondays.com. We're going to go ahead and pause for another quick break, but we'll be right back after this here on Medical Monday.
People with a lawyer get 3 times more money than people without one. Maybe that's why we're the law firm Middle Tennesseans trust after a car accident.
Fall is a beautiful time of the year. The weather is great, the leaves change colors, but when those leaves are falling and land inside your gutters, the appeal kind of goes away, right? So call now for Leaf Guard, the gutter that never clogs, guaranteed. Diane tells you why she called Leaf Guard.
So my husband would be up and down on the ladder and moving the ladder along and doing the next thing, and I was always afraid, like for the second story especially, that, you know, something would happen and he would fall.
Diane's glad she called Leaf Guard. You will be too. No more climbing the ladder to clean the gutters. Look at Leaf Guard. Ask about our clog-free guarantee and take advantage of our $99 installation sale. You buy Leaf Guard from us, we install it for $99. Ask about zero-interest financing for 18 months. And if you call now, we're going to double your gift with estimate from a $50 to $100 restaurant.com gift card. Call now. Be sure to check out Refer 8. Tell a friend about Leaf Guard. You get cash back. Tell enough friends you could get free gutters. Call today.
I can assure you we recommended it. In fact, we just had new ones put on at my mother's house within the last couple weeks. We didn't talk to anybody else, and I know they're relatively new over there, but she's been extremely pleased with work they did over there as well.
Virtually all of our customers say they'd recommend Leaf Guard to family and friends. Can you think of another home improvement company that so many people would want to recommend? Look at Leaf Guard, the gutter that never clogs, guaranteed. We offer a lifetime transferable warranty. All of our installers, employees of the company, take advantage of our $99 installation sale. Ask about zero-interest financing for 18 months, and we'll double your gift with estimate if you call now from a $50 to $100 restaurant.com gift card. Remember, dare to compare. Leaf Guard has the lowest price on a one-piece gutter system. Call today to take advantage of the $99 installation sale. Let me keep your gutters clean forever. Pick up the phone and call Leaf Guard for a free estimate now.
Eva Marie smoked 12,000 packs of cigarettes over 15 years. She quit, and now there's a new lung cancer screening that could save her life. You stopped smoking. Now start screening. No matter how much you smoked, early detection could save you. Talk to your doctor or learn more at savedbythescan.org.
The show that lets your voice be heard on the big issues.
Let's take a call from Frank. Hi, Frank.
Morning Line with Nick Ferris on News Channel 5 Plus. Middle Tennessee's biggest newsmakers waiting for your call.
Let's go to Buddy. Buddy, good morning.
Don't miss the next Morning Line beginning at 8 on News Channel 5 Plus.
All right, welcome back, everyone. You're watching Medical Monday here on News Channel 5 Plus. I've got Dr. Pat Whitworth joining me tonight. We've had a great conversation this evening and appreciate those calls coming in here on the Plus. And we're talking about advancements in breast cancer treatments, misconceptions, things to look out for. And let's go back into treatments. As we were talking over the break, we wanted to discuss why certain treatments over others, for instance, chemotherapy.
Well, you know, we use chemotherapy sometimes, and in fact nowadays we used it for a lot of time. We used it for everybody, or almost everybody, and we've learned now who really needs it, and it's a minority of patients. Now, we do some systemic treatment for almost everybody. By systemic treatment, I mean it's either a pill or maybe it's an IV, but it goes throughout the body. It goes other places besides just the breast. Why do we do that? It's because of statistics, really. There is, with any breast cancer, we can do some calculations, but we can calculate the chance that there's a cancer cell somewhere else in the body. And so if there's a cancer cell in a bone, the surgery, and if we do lumpectomy and radiation, those just treat the breast. That doesn't do anything about that cancer cell somewhere else. And we've gotten a lot better at this. We're still not perfect at it. Most people do not have a cancer cell somewhere else. But we don't have a scan or any kind of test right now that can tell us for sure. So if there's a significant risk of there being a cancer cell somewhere else, and depending on the patient, we can say there's a higher or lower risk, then we say we want that cell to die. We want to kill that cell. Sometimes we find it's a type that needs chemo to kill that cell that's somewhere else. Sometimes we find it's a type that just needs a hormone blocking medicine. If that cell is dependent on hormones and we block the hormones, that cell will die. So those treatments are given not to treat the breast so much, but to treat a cell that's out there, because if a cell becomes a tumor somewhere else, then we can't cure it, or very rarely can we cure it. So we want sort of a preemptive strike before that cell can get out of hand. One of the big advances that we've had in the last few years is that these days, instead of just looking at how big is the tumor, we look at that tumor type, and if we see this is a tumor type that needs chemotherapy, for instance, or maybe that needs hormone blocking medicine, we'll give that medicine for a period of time before surgery. And with some of the most scary cancers, the ones that we scare people about, most are still cured, but we say, oh, this one's a little worse. With some of the scarier ones, we give that treatment before surgery and the tumor disappears completely. And it's sort of a nice test, you know, is this the right medicine? If the tumor disappears in the breast, we can believe it's probably disappearing if there's a cell out there. So in many cases we give preoperative treatment just to, number one, make sure that that is the right medicine and that tumor shrinks, but sometimes because it changes something where we had to do a mastectomy into a lumpectomy. And that's kind of nice. These days, mastectomy is a lot nicer than it used to be. We do
and that
often
is a scary word to a lot of folks, too.
It is. We do what's called skin-sparing mastectomies. I hope women haven't seen those old pictures of women that had a skin graft. We do skin-preserving, and we also do nipple-sparing mastectomies. So in a lot of cases, especially in a young woman who maybe has a gene abnormality who wants to have both sides mastectomies, we'll do a nipple-sparing mastectomy with immediate reconstruction. Plastic surgeon does the first step in the reconstruction right then. And I love that situation when it happens, because a lot of times that woman's friends won't believe her. You know, it's the South, so she'll say, you know, I had to have a mastectomy, and they'll say, bless her heart, she thinks she had a mastectomy. I saw her, she didn't have that.
She did opposite.
That's what, if somebody has to have that, that's what we want to hear.
Kind of that old way of thinking. Yes. I think it's incredible. You brought in some great information. Let's go ahead and anything else you want to touch base on that, about that post-operative, you know, again, that's also an important side of this as well.
Well, on the other end of the spectrum, you know, we are discovering cancers smaller and smaller and smaller. And we are still doing kind of the standard procedures. We've made big advances with lumpectomy, you know, and now, as we talked about, adding plastic surgery techniques to lumpectomy, lifting the breast a little bit, or doing a reduction, or using partial breast prosthesis in a radiation marker. But we are realizing that we're in many cases kind of taking more tissue than we need to. And so there's a new device now called the Intact device, and it really was developed as a biopsy device, but it can actually remove a lesion. And we used it, and it's used mostly to remove just an abnormality on a mammogram. It'll remove it. Patients say, you know, you're going to do a biopsy, are you going to remove it? And, you know, a lot of times we say, well, we don't need to, we'll find out. But this device can remove a lesion, and if it's one of those ones that has some abnormal cells that maybe aren't cancer, but they're on the borderline, you can remove that lesion with this little basket device. And what we've done in a study we did at several centers around the country is to use that for small cancers, because we're finding cancers that are, you know, 3 or 4 or 5 or 6 millimeters in size, less than 1/4 of an inch. And so we've begun to use that technique to do the lumpectomy, and we still can get the whole thing out with a rim of normal tissue.
You know, and again, bringing up lumpectomies again, we'll talk about this BioZorb again if maybe folks are just now tuning in, a device that we first introduced as we kicked off the show tonight. Incredible. This is really, it's a 3D marker that helps identify the surgical site after the removal of tissue. Kind of acts as a filler in a way, and this dissolves on its own. So it's an incredible, just another option that we have now. It's just, you know, again, the advancements is what we're talking about this evening. And then moving forward, you know, I think a lot of folks, one of the big questions, you know, the word cancer is a scary one, and a lot of folks want to know, well, what can I do to, in any sort of way, you can't always prevent it, but what are some things we can do? Exercise, eating healthy. You know, as a doctor, what's kind of your standpoint on this?
Well, lifestyle choices can impact risk, although they're all very difficult, you know. We know that the hormone-dependent cancers can be more frequent in women who are really over their healthy weight. If a woman is overweight, what happens is there's an enzyme in the fat cells of the body. That enzyme converts hormones from your adrenal glands into estrogen. So if you gain weight, your estrogen levels go up. Some women may have noticed that, you know, if they have some fibrocystic condition or some breast pain, if they gain some weight, their breast tenderness is greater. Their breast pain is more than it was before. So that estrogen level is sort of tied to your weight to some degree. So we don't think everyone should be too thin, but being in a middle range of weight, a healthy range, is good. I hear a lot of times people say, well, you know, cancers are dependent on sugars, but really all cells in the body are dependent on carbohydrates. That said, high carbohydrates has been a problem in this country for a while because we went through a craze where we said avoid all fats, fat-free, low fat, and now we figured out in the last few years that was kind of a mistake, because what makes fat, you would think eating fat makes fat. Eating carbohydrates makes fat. So you want to have a good balance. You don't want to go to 0 carbohydrates, but sugar makes fat.
Yeah, all sugar's bad. Yeah, when it comes in the forms of pies and cookies, I guess. So.
But still, you can have a pie.
Okay, okay. You know. We'll still have pie, room for pie. Yeah, I mean, that is great advice. I mean, of course, I think common sense ties in with, you know, the healthier we eat, the better care we take of ourselves, you know, the better outcome we will have. And now let's talk to you about maybe the fact that, you know, when it is in a family, what's the best advice you have for, say, you know, a younger woman who maybe her grandmother or mother has been diagnosed with breast cancer? What would be your best advice? What would you like to see them do?
That's a very important question. I think, you know, we have advice for what women should do, but we haven't been giving them enough information about the fact that they can tell what their risk is, what their lifetime risk is. So I think every woman should get informed about her lifetime risk. And at St. Thomas Midtown, and now the whole St. Thomas system, and throughout the advanced health system, we're moving toward calculating that lifetime risk when a woman comes in for a mammogram. As part of that screening mammogram, we calculate her lifetime risk, because again, if that lifetime risk calculates to be greater than 1 in 5, greater than 20%, we think we should add MRI as part of her screening in many cases. So there are several online tools, calculators, that we can use. So that woman that wants to know, what should I do? I've got a strong family history, I'm concerned. She needs to ask her gynecologist or her doctor, her primary care doctor, can you calculate that risk for me? I really want to know what my lifetime risk is. And many of those doctors will say, sure, I'll do that. But some of them will say, I'm going to send you to a breast specialist. And a breast specialist should certainly be in a position to calculate that risk for that woman. And then she can tailor, does she need a little more screening than the average?
I think, that is an important question to ask, kind of that early detection, going back to that. And how important, with all the advancements we've made, is it still vital? We always hear growing up as young women, to do those at-home exams. And a lot of times I don't think folks really know if they're doing those correctly. Is that still one that you all encourage doing? Or
we do, especially for younger women. Now, it's controversial because mostly what you find are benign things that just scared the person. You gave them good news, you don't have breast cancer, but now you've got high blood pressure because we scared you, with this lump. But we do think, I think, and most breast specialists believe, women should check about once a month. And you're not looking for a little change where you say, is that different? I can't tell. You're looking for something where you say, wow, that's different. And when you have a change where you say, man, that's a real difference, then you should check that out for sure. It's still mostly going to be a benign change, but if it's something, you can catch it early. The challenge with young women and the challenge with denser breast tissue in general is that it's very hard to diagnose compared to a woman who has a less dense breast or an older woman. As a woman ages, 50s, 60s, and 70s, that glandular breast tissue changes to more fatty tissue. Well, fatty tissue on a mammogram is black, and cancers are white. They stand out. You can easily find those on a mammogram in most cases in a woman in her 60s or so. In a woman in her 40s, it's very hard, and that glandular breast tissue looks white on the mammogram. Cancers look white. You can't find a polar bear in a snowstorm until it gets to a certain point. It scares these women to death because they think, well, it wasn't here yesterday, and now today it's this big. But that just means it kind of crossed the threshold where you could feel it.
Okay.
But that once-a-month self-exam is important. Certainly the once-a-year exam with your specialist is important too.
Yeah, just a few more minutes here before we break again. I wanted to ask you, you did touch base on the age spectrum. How do you go about things differently with, from a very young woman in the treatment and maybe some of the care? Of course, both are of most importance equally. But how do you have to do things a little differently, say someone who more leaning towards an elderly age getting diagnosed versus someone in, maybe their early 20s, mid-20s, kind of in the younger end of the spectrum?
Well, things are changing. Things are sort of changing all the time, but we have gotten very, very comfortable with the lumpectomy plus radiation approach. The results are very good with some of the techniques that we're talking about. So more and more women in their 50s, 60s, and 70s are making that choice. Younger women, the survival chances are exactly the same, but they're also worried about having another event in a lot of cases. You're going to cure this, and if something else happens, you're going to find it way earlier than this, so it's not, you're going to cure that, but what's my risk? So if a woman has one of those gene mutations, we start to think about the nipple-sparing mastectomy approach instead of the lumpectomy approach. So a younger woman with a gene mutation, no doubt we start thinking about that a little more. And a younger woman in general, we start thinking about genetic testing a little more. It's a little more difficult to diagnose in those folks who are young women with a complicated exam and a strong family history. We're very pleased that usually we calculate that lifetime risk. It's over 20%, and we can get an MRI to really help us sort that out.
Incredible. I think too, just kind of, surgery always, it can be a little harder on someone, in an older age, but again, those advancements and the things we've been talking about tonight, we have definitely come a long way. All right, well, lots to talk about tonight. Dr. Pat Whitworth, we appreciate you joining us tonight. We're going to go ahead and pause for one more quick break. Keep it right here on News Channel 5 Plus. And if you do have any questions, stories you want to share, comments or concerns, feel free to call in. I'm going to go ahead and give you that number before we pause for break again. It's 615-737-PLUS. That's 615-737-7587. We'd love to hear from you. Any questions you may have tonight, hopefully we can get those answered for you. Keep it right here on News Channel 5 Plus. We'll be right back.
This is a Storm 5 HD weather update. Sign up for weather call at newschannel5.com.
Hi, everyone. I'm News Channel 5 meteorologist Leland Statham. Thank you for watching News Channel 5 Plus. Radar rain free for us here in the mid-state today. There could be a stray shower toward the west state, but most areas will be dry. Check out what's happening right now as far as our temps are concerned. Another very warm day. The normal high 79. We're shooting for 91. The record today, 92, set back in the 1800s. Let's show you what's happening right now from Nashville International. So your Tuesday forecast, looking for a high today of 91 with a wind east-northeast right around 5 miles per hour for you today. Meanwhile, overnight tonight, mainly clear down to 66. We're still at 90 tomorrow. Cool fronts on the way. It may squeeze out a stray shower Wednesday, Thursday. Most folks dry, but it will bring much cooler weather for the weekend ahead.
There's no single answer to securing your financial future. You need to look at it from every side. Get dependable advice you can count on every week with the Retirement Report on News Channel 5 Plus. Experts on finance, taxes, and the legal system are ready to answer your questions. Don't wait to make a plan for your money. The Retirement Report, Friday mornings at 8 and at these encore times on News Channel 5 Plus.
Your son wants to get a cat, but you're allergic. Do you A, prepare yourself, B, make the best of it,
C squared equals 25. Good job!
or C, find a loophole? When it comes to parenting, there are no perfect answers, but that's okay, because you don't have to be perfect to be a perfect parent. Teens in foster care will love you just the same.
Well, welcome back to The Plus here for your Medical Monday tonight. We appreciate you joining us. We've had Dr. Pat Whitworth here all evening giving us so much vital information. Doctor, we appreciate your time. Anything you want to kind of leave us with tonight on this topic of advancements in breast cancer treatments?
I think the main thing is, like we talked about, it's important if you have a question or a new symptom or a concern to get that checked out. Women have been for many years afraid of what would happen to them if they went and saw the doctor, and they had good reason. These days, number one, most things that we do are much easier than they used to be. Biopsies are not done in the operating room with an incision. They're done as a small needle biopsy. Most biopsies are benign, even if you have to have one. Even when a cancer is diagnosed, the vast majority of those are cured. So those are good things. Sometimes a scary cancer is there, and sometimes we really need to intervene, but sooner's better than later.
Well, doctor, thanks so much for joining us.